lecture on childhood urinary tract infection. Over to you, sir.
I would like to thank the President of the Council of JMA for giving me this opportunity and inviting me to deliver this lecture. And I must say that it's both a privilege and a pleasure, though I'm not there in person. Uh, I've titled my talk, Childhood Urinary Tract Infections, Changing Paradigms, because the management of this simple childhood infection has changed quite remarkably over the last decade or so. And new evidence has come into being, but many units in this country and in some areas of the world still practice the old guideline, which has been refuted. So to start with an overview, during the course of this lecture, I'll be introducing you to childhood urinary tract infections. I'll be dealing with the old Royal College of Physicians and British Association of Pediatric Nephrologists guidelines of 1991, which basically stood true for almost 2 decades and is still practiced, as I mentioned, in some parts of the country and in some parts of the world as well. I'd be dealing with the implications of this guideline and following it up with new evidence that has since emerged. And we'll be ending with the current NICE guideline of September 2017. And I'll be touching on the new Sri Lanka College of Pediatricians guidelines on childhood urinary tract infections, which are scheduled to be put out very shortly. So a urinary tract infection in children can be defined as the presence of more than 10 to the power of 5 colony-forming units per milliliter of urine of a single organism in a properly collected sample from a symptomatic patient. Now, all these terms in this definition are extremely important. The patient should be symptomatic. It should be properly collected samples, so bag samples and delayed samples are not valid. It should be a single organism, so mixed growths are not valid. And if it is a clean catch sample, there should be more than 10 to the power of 5 colony-forming units. So all the terms in the definition are important. As you know, E. coli is the commonest organism, and childhood urinary tract infections are important because of their association with reflux nephropathy, and in turn, its association with hypertension and chronic renal failure. Now, the lifetime risk of getting a UTI has been calculated to be about 1 to 2% in boys, and this is 3 times more common in girls. However, in the first 3 months of life, as with other infections, UTIs are also commoner in boys. And they've also found that there is a 10 times higher incidence of UTIs in uncircumcised males. So circumcision is preventive. What makes you susceptible to your UTI? Genital abnormalities like tight prepuce or phimosis makes you susceptible. Labial adhesions also make you susceptible. So these, you need to look for these in your examination. Voiding dysfunction may be pathological, as in a patient with a neurogenic bladder, but it also may be functional, as with constipation. And you get these young girls or school-going girls who do not like to void urine at school because of the poor hygiene in the toilets. So they just keep their urine in for prolonged periods of time. And this makes them very, very susceptible to urinary tract infections. And I've even had about 2 or 3 girls who developed mild degrees of vesicouretic reflux just by this voiding dysfunction and holding the urine in. Reflux, vesicouretic reflux, and urinary tract obstruction would also obviously make the patient susceptible to urinary tract infections. Now, traditionally, urinary tract infections have been classified as afebrile and febrile UTIs. Afebrile UTIs are synonymous with cystitis, so you get the lower urinary tract symptoms or LUTs, which include dysuria, frequency, urgency, and so on. Febrile UTIs are synonymous with pyelonephritis. In young infants, these symptoms of febrile symptoms of UTI can be very vague and very difficult to grasp. There can be excessive crying, irritability, lethargy, so very vague symptoms. So we need a high degree of suspicion to diagnose a UTI. Older children present with the more common and more well-known symptoms of UTI, like chills and rigors and vomiting and loin pain. I've just put this simple slide just to emphasize the importance of the simple urine analysis or simple UFR. The UFR obviously shows you pyuria and bacteriuria, but it is extremely important to couple both the UFR and the urine culture to diagnose a UTI. The AAP guidelines, the current AAP guidelines, recommend that you need to have a positive UFR as well as a urine culture to diagnose a UTI. That's the importance that's given to the simple UFR. So you need both the UFR and the culture to come to a definitive diagnosis. This is because if your UFR is negative and your culture only is positive, this could be due to preputial colonization of bacteria. It could be due to bacteriuria, due to asymptomatic bacteriuria, and it also may be due to improper collection techniques. So to overcome this, you need to couple both the UFR and the culture to diagnose a UTI. So culture is obviously gold standard, but it has to be coupled with a positive UFR. Leukocyte esterase basically detects pyuria. Nitrites detect bacteriuria or the urea splitting organisms, and these two are also helpful in making a diagnosis of UTI. Treatment, intravenous versus oral, how do you choose? There are no clear-cut recommendations, but in general, the younger the child, the more often you go for the intravenous route. And in neonates, the entire course should be given intravenously, and in children under 3 months, for that matter, also you need to at least start with an intravenous antibiotic and continue it for the majority of the course. Older children, if they are ill and septic, start with an IV antibiotic, and you can switch to an oral antibiotic once the child has been afebrile for 24 to 48 hours. In other children who are relatively well, you can go with oral antibiotics, but these all should be tissue-penetrating antibiotics. Now, the duration of antibiotics for a febrile UTI should be 7 to 14 days. And in my personal practice, I go for 10 to 14 days because of the poor quality of the antibiotics we have locally. This is extremely important because it's always tempting to stop at 5 to 7 days because your fever usually settles. If it's a typical infection, your fever will usually settle within 24 to 48 hours. It's typical. It's tempting to stop early, but we need to continue it for 10 to 14 days, or at least 7 to 14 days, because if we do stop it early, there is very frequently a re-emergence of the same infection. The choice of an empirical antibiotic depends on the sensitivity pattern of your unit. This is not difficult to do. All you need to do is just go through the urine cultures over the last year, and you just find out what antibiotics the common organisms that cause UTIs are susceptible to. And if it is a tissue-penetrating antibiotic, that would be your antibiotic of choice. In our unit, we use coamoxiclav and cefuroxime as first-line empirical antibiotics. If the child is not very ill, they're very ill, we go for cefotaxime. You need to avoid nephrotoxic antibiotics, namely the aminoglycosides. Now, I know the AAP guidelines and the NICE guidelines both recommend the use of gentamicin and amikacin in certain instances, but remember that they monitor gentamicin levels, so it's safe in their circumstances. But we do not have gentamicin levels. So it's best to avoid, especially if you have an alternative tissue-penetrating antibiotic. So if you have an alternative, by all means, use the alternative and avoid gentamicin and amikacin. You may be pushed against a wall where your child is very ill and septic, and the only antibiotic your culture is sensitive to is gentamicin. Then, by all means, you need to use it. But if there is an alternative, please avoid aminoglycosides. From now on, I'm just going to deal with the RCP and BAP and consensus statement for the management of childhood UTIs of 1991. Now, this guideline stood true for a good 20 years and is still practiced very diligently. It was practiced diligently for 20 years all over the world, and it's still practiced in certain units here as well as in other countries. Now, this guideline involved very extensive investigations in all patients with urinary tract infections. They recommended an ultrasound scan and a DMSA in all patients who have a urinary tract infection. And in those under 1 year, they also recommended an MCUG. So all three, if you had a UTI under 1 year. Between 1 and 7 years, if MCUG was recommended if there were recurrent UTIs, if there was a family history of reflux, or if there were abnormalities on your ultrasound scan or DMSA. If they were above 7 years, MCUG was recommended for abnormalities on ultrasound scan and DMSA, or if the UTI was a recurrent UTI. So there was extensive investigation. What were the other recommendations? There was antibiotic prophylaxis was recommended to all children up to the age of 5 years, even with a simple UTI in infancy. They recommended that regular cultures, regular 3-monthly cultures were done to monitor reinfections. And these reinfections, even though the children were asymptomatic, were treated as UTIs, and the child was branded as having a recurrent UTI and underwent an MCUG in addition to the DMSA and ultrasound scan. So further imaging for these recurrent UTIs was recommended. They also did an MCUG for a family history of vesiculated reflux, and they recommended surgical intervention for grades 4 and grade 5 reflux in all patients. What were the implications of the 1991 guideline? There was massive overdiagnosis of UTI and massive overtreatment because asymptomatic cultures were treated as UTIs. This led to excessive investigations and extensive imaging with radiation and discomfort to the children. All this came at an enormous cost and tremendous parental anxiety. What was achieved? Basically nothing. There was no reduction in the incidence of renal scarring. There was no reduction in the incidence of hypertension. And there was no reduction in the incidence of chronic renal failure. So researchers looked for scientific evidence elsewhere. And they focused their research on the value of imaging studies, the value of prophylaxis, the value of anti-reflux surgery, the value of doing routine cultures in asymptomatic patients, and the value of treating asymptomatic bacteriuria. What is the new evidence that has emerged? Renal scars have been demonstrated even in the newborn. They've been found even in the absence of vesiculated reflux, and scars have developed and enlarged even without having a urinary tract infection. So VUR and UTIs are not the only cause of scar. Scars also were found, it was also found that development and enlargement of scars after the age of 4 years was extremely rare. So even if you have a pyelonephritis after about 4 to 5 years, those infections do not usually cause renal scarring. So DMSA is not needed. And they've also identified genes that are responsible for renal scarring and reflux. Contrast, MCUG is no longer considered the gold standard to diagnose VUR. A good radiologist with a good machine can easily diagnose vesiculated reflux on ultrasound scan. The evidence does not support the active management of asymptomatic bacteria, so you should not treat asymptomatic bacteria. Prophylactic antibiotics are not effective in preventing renal scarring. The onus is on early institution of treatment. Prophylactic antibiotics only prevent infections, but they do not prevent the development of scars. Surgical intervention for reflux in the form of reimplantation did not alter the rate of renal scarring and did not alter the rate of progression to chronic renal failure. So based on these findings came out the new NICE guidelines of 2007 and 17, which are very similar. And these guidelines categorized patients with urinary tract infections as having atypical infections and typical infection. And the idea behind this classification is to identify which patients need further extensive investigation and which patients do not. So the patients with atypical features, which are a definite minority, they're the only ones who need the extensive investigations. The vast majority of patients will have typical urinary tract infections and they do not need extensive imaging. So what are the characteristics of atypical infection? If the child is very ill and septic, if there is a poor flow to urine at all times, not only during the infection, if there are palatable kidneys or palpable bladder, if there's a raised creatinine level, and if the patient fails to respond to the appropriate antibiotic within 48 hours. And if there are infections with non-E. coli organisms, especially Pseudomonas and Enterococci. So if these features are there, these patients are classified as atypical infections, as having atypical infections, and they are the only ones who require extensive management, extensive investigation. So with these were born the new NICE guidelines, and these guidelines recommend for infants under 6 months of age, if the patient's infection or the fever responds within 48 hours to treatment, they're classified as typical. So if they have a typical infection, all you need is a non-urgent ultrasound scan within 6 weeks, no DMSA and no MCU. However, if they do have atypical features or classified as an atypical infection under 6 months of age, it says you do an ultrasound scan urgently, as well as a DMSA and an MCUG. Sorry. If the patient has recurrent urinary tract infections, a recurrent UTI is classified as 2 urinary tract infections, of which at least 1 should be a febrile UTI, or 3 lower urinary tract infections. So if you have recurrent UTIs under 6 months of age, again, you need an urgent ultrasound scan, DMSA, and an MCU. So this is for infants under 6 months of age. For those between 6 months and 3 years of age, your NICE guidelines do not recommend any investigations if the child has a typical urinary tract infection. However, in the West, before children are born, they have had several ultrasound scans, so there's ample opportunity to diagnose. So there's ample opportunity to detect tract anomalies. So in our local guideline, which we are about to publish very soon, we recommend a non-urgent ultrasound scan for these children. If they have a typical urinary tract infection responding within 48 hours. If they have atypical features under 6 months of age, we do an urgent ultrasound scan and a DMSA in 6 months, but an MCUG is done only if there are abnormalities on ultrasound scan. Recurrent UTI, again, a non-urgent ultrasound scan and a DMSA in 6 months. MCUG only if there are abnormalities on ultrasound scan suggestive of high degrees of vesiculated reflux. For children older than 3 years, again, the NICE guideline, if the infection is typical, the NICE guideline does not recommend any investigations. We in our SLCP guideline have recommended a non-urgent ultrasound scan. Atypical infections over 3 years of age, they require only an urgent ultrasound scan, so no DMSA and MCUG, unless, of course, the child has abnormalities on ultrasound scan. For recurrent UTI, you do a non-urgent ultrasound scan and a DMSA, no MCUG unless there are gross abnormalities on ultrasound scan. So the investigations have been cut down quite remarkably. And this slide gives you a summary of notable guidelines world over. You've got the NICE guideline, the American Academy of Pediatrics guidelines, and the Australian guidelines, along with the Indian and Italian guidelines. So you'd see that ultrasound scanning is recommended in all the guidelines. MCUG or VCUG, avoiding cystourethrogram. The Australian and American guidelines do not recommend an MCUG unless there are abnormalities on ultrasound scan. However, the NICE guideline recommends them in patients with atypical or recurrent UTI under the age of 6 months. Notable here is that the American guideline and the Australian guideline have completely done away with DMSA scans, though the NICE guidelines recommend them if there are atypical or recurrent urinary tract infection. Another point of note is that the Indian guidelines still stick to the 1991 BAPN guideline and recommend all these 3 entities for all patients. Now, this is not without cause. A lot of patients in India have have poor access to hospitals and are in rural areas. So if you do not investigate them at the outset, they'd be lost to follow-up. And this would lead to patients popping up with advanced renal failure later. So when you catch them, you need to investigate them. Otherwise, it's going to lead to problems. So it's not without cause that they do so. What are the other evidence-based recommendations? Positive urine cultures in asymptomatic patients require no treatment. For that matter, cultures should not be done in asymptomatic patients. Routine circumcision is not recommended, but if there are recurrent UTIs, you need to go for a circumcision. Even severe grades of reflux, grade 4 and 5, can be managed with prophylactic antibiotics if they have recurrent UTIs. And you can utilize the practice of double voiding or triple voiding so that the reflux urine is voided, and this can prevent reimplantation and recurrent infections. So you need reimplantation only if there are troublesome urinary tract infections despite this medical management. What about prophylaxis? Prophylaxis should not routinely be recommended in infants and children following the first UTI, even if there are structural abnormalities. So if the parents can be responsible enough or reliable enough to seek medical advice when the child is symptomatic, as soon as the child is symptomatic, and get a UFR done, and if it is positive, get treatment with antibiotics early, you don't need prophylaxis. So you don't need to start routine prophylaxis in all patients, but in those with recurrent troublesome infections, prophylaxis is recommended to prevent UTI. So the onus is with early treatment rather than in using prophylaxis to prevent infection. So if you manage to treat the infection within 24 to 48 hours or start treatment within 24 to 48 hours, that infection is not going to lead to scarring. So if your parents are responsible, that is what you should do. The problem with prophylaxis is that it breeds resistance, antibiotic resistance, and these resistant organisms, if they cause UTIs in transplant patients and in patients with complex urinary tracts, it can be very, very difficult to treat. Asymptomatic bacteria should not be treated with prophylactic antibiotics. Long-term follow-up is needed for patients with renal scarring and reflux. Blood pressure monitoring, this is in the form of blood pressure monitoring every 3 to 6 months. We do the renal functions every 6 months. If there is bilateral involvement, unilateral involvement, annual renal functions are sufficient. Renal growth needs to be monitored with serial ultrasound scans every 1 to 2 years. Further imaging like DTPA, MAG3, and IVU are required if there are obstructive lesions, and patients with recurrent UTIs are candidates for the use of prophylactic antibiotics. So in summary, typical UTIs need minimal imaging without long-term follow-up and without prophylaxis. The current emphasis is on rapid institution of treatment rather than extensive investigations. Prophylaxis. Atypical and recurrent UTIs need advanced imaging with or without prophylaxis, and long-term follow-up is necessary for children with renal scarring and urinary tract abnormalities. Thank you.
Thank you, Dr. Dalgakoda, for your detailed and evidence-based clinical practice and recommendation in childhood urinary tract infection. As we are running behind the time, we will move on to the second lecture, rickettsial infection in Sri Lanka. I'll introduce the second speaker, Professor Ranjan Premaratne, Senior Professor in Medicine, Department of Medicine, University of Kelaniya, Honorary Consultant Physician, Colombo North Teaching Hospital, Ragama. Professor Premaratne is a well-known to Sri Lankan medical professional through his remarkable interest in infectious disease, including rickettsial disease, and he is the head of Rickettsial Disease Diagnostic and Research Laboratory at Faculty of Medicine, University of Kelaniya. He has held and is holding multiple eminent positions as a council member, examiner, editor, as well as chairman in various international, national, and university levels. So without delay, I cordially welcome Professor Ranjan Premaratna to speak on his favorite topic, rickettsial infection in Sri Lanka. Over to you, sir.
Thank you very much. Can you all hear me?
Yes.
Oh, please. Yeah. Thank you very much for inviting me to this symposium, your 80th annual academic sessions. Since we are running behind time, I'll just straight away go for the lecture. I'm going to touch upon rickettsial infections. In fact, it will not be really a Sri Lankan point of view, but I'll just go to a little bit of introduction as well. Right. So during the next 20 to 25 minutes, I thought I would sort of briefly go through the epidemiology and evolution of rickettsial diseases and their transmission, and then come into the topic a little briefly, rickettsial disease in Sri Lanka. Then I was sort of asked to elaborate a little bit on clinical features because there are some medical students in this audience. So I'll be going a little more in detail on clinical features and to share my experience of rickettsioses in Jaffna as well. That's again a very brief encounter. And as time permits, I'll discuss some clinical cases. But I think if you are running behind time, or if I go over time, you may stop me at any time. Right. So briefly on epidemiology and evolution of rickettsial diseases. Rickettsial diseases, of course, represent some of the oldest and most recently recognized infections diseases. Uh, as an example, Nathan's plague described vividly in 5th century BC was thought to be due to epidemic typhus. So in 1916, Rickettsial was identified as the etiological agent of epidemic typhus by Prowazeki himself. It is a gram-negative rod-shaped organism, an obligate intracellular bacteria which resides freely in the cytoplasm of eukaryotic cells. It has remarkable gene reduction and therefore it depends on host cytosolic environment. It needs the cell support of the host for growth as well as for division, and it has an average generation time of about 8 to 9 hours. Then by 1970 to 1980, they discovered or they sort of identified 4 rickettsial species unique to the different 4 geographies. That is Rocky Mountain spotted fever to Americas, Mediterranean spotted fever to Mediterranean regions, then North Asian tick typhus to Asian region, and Queensland tick typhus to Australia. So after 1990s, since the identification or implementation of molecular techniques, there's a vast sort of identification of rickettsial species and genotypic characterization of this organism and accounting to sort of development of this species and subspecies in spotted fevers and the rest of the organisms. So family Rickettsiaceae include general Rickettsia, that is spotted fever group and the typhus group. Then spotted fever group, if you look at, it has 25 officially validated species, 16 of which are thought human or confirmed as human pathogens. Then there is a transitional group between spotted fever and typhus group. These are Rickettsia australis, Akari, and Felis, because they have evolutionary genetic relationships in between. Then the Orantia Sutsugamushi, which was initially in the Rickettsia genera itself, but it was separated from that in 1995 based on its antigenic diversity. So it is now called scrub typhus or the Orantia Sutsugamushi. I think that is the most prevalent Rickettsial species or the typhus group species, which is found in northern Sri Lanka or Jaffna. Looking briefly on transmission of rickettsial diseases, they're transmitted by ticks, fleas, mites, and other arthropods. So spotted fever mainly by ticks and fleas, that is Rickettsia felis, and mites, Rickettsia cari. Then the typhus group, the oldenmost, the Rickettsia prowazekii, which caused a massive number of deaths during world wars, which are transmitted by human body louse. Then Rickettsia typhi is transmitted by fleas, or the murine typhus. Then Orientia Sutsugamushi, as you all know, from the good olden days, it is the chiga mite, which is supposed to be transmitting this organism, the larval stages of the chiga mite. Then looking at the transmission cycle, of course, you can appreciate here these organisms are mainly found in these ticks and mites. If you take, if it's tick-borne, it's ticks. So they will have the vertical as well as horizontal transmission. The ones which are not infected can acquire these organisms through infected rodents, and then they can sort of transmit vertically, that is from the infected female adult transovariate to the infecting eggs, and the nymph stages which are going to develop after that will have the rickettsial organisms in them transmitting the illness. So basically, human is an accidental but is a dead end host, because you will not get transmitting rickettsia from human to any other arthropod or any other vectors. So the various spotted fever groups, again, you will appreciate it is sort of transmitted by ticks and acquiring the organism these from these wild or domesticated rodents. Right, typhus group similarly, it's the fleas and then the louse, body louse, which will be transmitting accident to the humans. Then scrub typhus similarly, you get the chigamites. The 8-legged ones is not going to feed on any of the rodents or the human. It's the 6-legged one, which needs a single tissue meal during its development. So again, an accidental human is an accidental host. When sort of man or whatever accidentally you go to a forest or whatever, or where there is vegetation, where there are a lot of six-legged mites, then can get accidentally bitten and can get the infection. Then going to the rickettsial diseases very briefly in Sri Lanka, the documented literature dates back to the World Wars, as I said initially, because if you read through, you will find that there had been a fierce attack or ground attack by chigamites on British troops landing in Sri Lanka at that time, causing high morbidity and mortality. And this, in fact, had been a very, very scary situation at that time. Then the infection is prevalent in almost all parts of Sri Lanka. However, spotted fever is predominating in the hilly central province and scrub typhus mainly in the lowland, dry or wet zones. The organisms that we have commonly encountered are the scrub typhus or Rickettsial utsugamoshi. Then out of the spotted fever rickettsioses, the most common one is Rickettsial conuri. Then the Rickettsial, the murine typhus, also had been described in Sri Lanka. This is a study done by Peradeniya group, Professor Devanesam and others, was published in 2011. This is a patient-based sero-epidemiological surveillance. If you can see these dots, the yellow ones, which indicate the predominance of spotted fever group, which in the hilly central province, and the orange stars, the scrub typhus, you will see they are mainly in the lowland or dry or the wet zones. But it does not mean that they don't this spotted fever does not exist here. We see peridomestic spread of spotted fever in the lowlands as well. Then there's another case study which I could retrieve in the internet. Jaffna, one of your colleagues, has described the clinical features of emerging scrub typhus in northern Sri Lanka, and I'll come to that paper later on. Then going from there to clinical presentations of rickettsioses, I think probably you all are very familiar with this infection by now, but just to recap some of the clinical manifestations. You can see, this is not the data from Sri Lanka, but this taking all the data. I have produced this simplified graph, you get the symptomatic end as well as the asymptomatic end for rickettsioses. Then, of course, the symptomatic illness is caused by more virulent ones like Rocky Mountain spotted fever, which carrying about 25% mortality. At the same time, the other end, the African tick bite fever, which does not usually cause any mortality, and that is because the lesser virulence of that. So all these infections have this non-specific symptomatology like fever, headache, myalgia, and arthralgia, and they may pass as any of other febrile illness without causing any morbidity, severe morbidity or mortality, and without any treatment they can improve. And the way that you could diagnose is either the presence of the rash or the pathognomon is Eschka, But again, these will have their own differential diagnosis as well. So if you miss the diagnosis, especially in the virulent end or even in moderate virulent ones, they will go into, I mean, if you don't start treatment timely, they can involve the rest of the organs like respiratory, CNS, CVS, renal, hepatic, or multi-organ involvement, causing severe complication and high morbidity and mortality. So the issue is, this more or less a clinical diagnosis. So you have to suspect this, and you should know the occurrence of it and the prevalence, and therefore you can start treatment timely and prevent these dreaded complications. So whom are we going to suspect rickettsioses? Well, as we said, it's a febrile illness. Then they will have fever with chills, trigos, headaches, and body aches, and so on. And the patient might not feel very ill in between fever. They will feel quite well, in fact, similar to malaria. But fever spikes can occur several times a day. And during the acute febrile phase, they can have very high febrile illness with very sort of severe body aches and pains and so on, as we discussed previously. Then if you do not diagnose timely, then this is going to happen. I mean, we have seen several patients coming this low-grade pyrexia of unknown origin with very minimal symptoms, but they will just continue to have this low-grade febrile illness. Right. So they can, again, similar to other tropical illnesses, can have a little bit of subconjunctival injection, hemorrhages, and so on. However, this is going to be more prominent at the time the patient is having fever. And this subconjunctival hemorrhages are not very common, but again, you might encounter some patients developing this as well. Then lymphadenopathy is a common feature, either regional or generalized lymphadenopathy. Of course, if the patient has got regional lymphadenopathy, one thing that you could do is you can examine this patient along the draining area, and you will be lucky to find this eschar in relation to that. But of course, if there is generalized lymphadenopathy, it will be difficult. Then this is the characteristic eschar, which will lead to a presumptive diagnosis. This basically the entry site of the organism, that is the bitten site by the vector, where the organism will enter. It will initially cause a necrotic sort of blistering lesion there, which is going to dry up with little bit of surrounding excoriation of the skin. Then the drying up skin will cause a scab, and the characteristic lesion will occur. But again, this may mimic any other scratch or a minor abrasion or a lesion as well. So you should always suspect if this is there in a patient with febrile illness. So these are some of the other sort of pictures of them. And of course, you can see here, there are two. Of course, if you see like this, there should be two mites ascending up. And this patient had been wearing the belt here, and they have ascended until they found the resistance and started feeding there. Because this mite does not, this chiga mite does not feed on several places. They will feed from the site they got attached initially. So there are two mites, of course, have bitten this patient. This in the breast. So you can see this nice eschar that they come with the black scab. When you remove this scab, you will get this nice crater with elevated edges. This is quite characteristic of this eschar. It can be very, very tiny and very, very small. You can see it's about, say, 1 millimeter over here. And the scab has swollen, so it's a healed one. But again, this may be important in a patient with febrile illness. That's why it is the most important is the suspicion rather than just going for a diagnosis. I mean, you have to suspect, and you start treatment, the patient will improve immediately. So this is the evolution of the scab over about 7 to 10 days. Initially blister, then it's going to dry up to a black scab, and this occurs over about 7 to 10 days. So the eschar is seen in about, say, 20 to 87% of scrub typhus patients. And in some of the spotted fever group rickettsioses, that's Rickettsial conuri, except in Rickettsial and Indian tick typhus, but it's about 80% in Mediterranean spotted fever group rickettsioses and others. And Rickettsial Africa, it's usually multiple. If you examine a patient, you will see many eschars in them. But again, as I said, it's a very, very mild illness. Then This ESHKA has its own differential diagnosis like urinary anthrax, tularemia, necrotic arachnism, rat bite fever, staphylococcus, ecthyma, and Barthelona-Hens Bay infection, and so on. Right, we have to look at, I think you can get it anywhere in the body, but common sites are at the sites of skin folds, strap of the garments, and wet areas like the perineum or the axilla and so on. So in a patient, if you really want to find that, you may look into these places. In females, below the breast and so on, so the perineal regions and so on. But again, it can occur anywhere in the body. These are the common sites published in the literature. Right. So these are about the rash. It's a very discrete rash. This is the ESHKA here, and these are very discrete rash that you will see in them. Then the rash has a very wide variability in evolution and distribution based on the illness that you're talking about. It appears 3 to 5 days after the fever, but may occur even late or early, mostly central. But commonly, we have not seen any rash in the face. So this is a good differentiation feature because other ones like measles and German measles and so on, they will include the face. The rash will be there in the face, but spares the face here. Then these are some of the differences in the Rocky Mountain spotted fever and so on. Then the rash can be confined to one body area as well. Then sometimes you can get maculopapulovesicular rash as well. So this our experience with the rash. This more or less, you can see it's a very discrete rash, erythematous maculopapular. It was more prominent because in our skin, it's sometimes very difficult to see that. But when you examine the patient at the time of the patient is at fever, you will see this rash, reddish rash, or the papules prominently on the dark skin. And mostly seen in the trunks, arms, and the palms and the soles. And it's common in spotted fever rather than scrub typhus. So you can see in the back or in the thighs, you can see this rash. Right. This rickettsial pox, it may appear, I have not seen any patients over here, but again, you may come across, especially when you get travelers, tourists coming into the country. These are some of the vesicular rashes that you may notice in rickettsial pox. Right. This, again, immunosuppression, you can get massive cutaneous eruptions with this illness. Right. This is the documented symptomatology of streptitis in Jaffna. I thought it will be interesting for you all as well, because it may be important for you. Right. So they basically are comparing the symptomatology of confirmed 54 patients of streptitis in the symptomatology of patients described in Western Sri Lanka and in Thailand. They have found a very high percent, 9% of ESHKA rate in them compared to the rest. And lymphadenopathy, of course, about 50%. Then hepatomegaly and splenomegaly detection rate is quite lower. But then again, headache and the rest of the complications are not very common. Of course, that could be related to their detection or early detection of this illness, probably because the presence of ESHKA. And ours is quite late, so they are maybe, because these are very early series that they have quoted here. So now we are sort of trying to detect them quite early. And if they're late, of course, the chances that they will get severe manifestation will be quite high. If you look at this exposure risk, they will have outdoor recreational or occupational activities, but most of these patients, it's more or less very domestic. You will not get these people going into these jungles or any other sort of wildlife sanctuaries or whatever. Then whether they have any activities near the high vegetation, sort of scrublands and so on, then whether they have gone on any camping, hiking, gardening and so on will be helpful. Then frequent contact with animals and those who have pets may be important, especially the pets like dogs will be important for spotted fever group because the dog, brown dog tick is the one which is responsible in Sri Lanka. Then historic tick bites, of course, they may realize they had been bitten by ticks because it's quite itchy and painful, and they may remember that they are removing these ticks. But mite bites are, I have never seen a patient who has sort of recalled a mite bite. It's very, very painless. Right. A little bit on my experience with rickettsioses in Jaffna. This, of course, is an acute outbreak of fever and cough or severe pneumonia among a group of military which is serving in forward defense line in Parali during the late 2008. Some were airlifted to National Hospital in Sri Lanka on a Sunday. Of course, it's not a great of an experience for me, where I usually don't go out on a Sunday. It's my time of sleeping. So I was having this differential diagnosis of whether they were having viral pneumonia, atypical pneumonia, bacterial pneumonia at that time. Then when I went to them, they were very ill. Some were dyspneic at rest. Then chest examination showed scattered post-scriptations, and some had reduction in capillary oxygen saturation, and they were serious ill as well. And the chest X-ray was quite patchy. And basic investigations are not very helpful except for rise in CRP and so on. It's like any other tropical febrile illness. So I was still thinking this could be acute pneumonia or bacterial pneumonia. However, until I saw this patient and this eschar on the face, which led me to diagnose that the patient was having strep typhus, causing severe pneumonia and pneumonitis syndrome. So we have published that as well. And if time permits, I think I have got another 5 minutes or 10 minutes. Yeah, I'll try to brief this. Few just to sort of give you some idea of it. Now, this patient came quite late in the illness, after about 10 days. When she came, she had very high fever, dry cough, shortness of breath, and so on. And she became very rapidly confused and restless. Patient had tinnitus in the ears. And later on, say within a matter of say few hours, she rapidly developed pneumonitis, myocarditis, then severe hearing loss, and she was basically deaf and caused tremors, and it was basically a nightmare. And we really did not know what was happening to this patient. And then on examination, we found this small, tiny lesion at the axilla. That was the point for the diagnosis. And we started treatment. At that time, chloramphenicol IV was available, and we gave, and we had, the patient had a very, very dramatic recovery. She became afebrile within 48 hours and rapid improvement in clinical condition and hearing impairment as well. So if you diagnose them quite early, although the patients were sinking, it is very rewarding because the patient will have a very rapid turn and patient will improve very, very rapidly. So this is the improvement of the patient, right? So the message is that if you find acute hearing loss together with any acute febrile illness, always suspect scrub typhus, or you may empirically start them on doxycycline. This is another patient. It's again a housewife, came with very high fever, a severe frontal headache, and the fever is going for about 8 days, vomiting, severe body aches, pains involving all joints. She was bedbound, she could not go out of the bed. She had a yellowish sclera, dark urine. Then he had history of vaginal discharge as well. You're thinking about this could be some septic illness or leptospirosis, because the thing is the patient had a history of exposure to floods. Very ill, icteric, dehydrated, symmetrical large and small joint arthritis, non-tender liver. So we had thought the leptospiral palindromic rheumatism, severe bacterial sepsis or meningitic process and so on. And the counts are also very high, CRP high, then creatinine was high, all are pointing for, even bilirubin was high, pointing for the possibility of leptospirosis. And we started treatment as for leptospirosis. However, she did not have any improvement but continued to deteriorate. But on the 10th day, that's the second day of admission, patient developed this rash of the body, this subcutaneous necrosis, which is called the fern leaf rash, that is everywhere in the body, basically. And that gave us the most likely possibility of rickettsial illness. So the message is that if any patient that you are struggling with develop this sort of a rash, you have to always suspect this could be rickettsioses, right? Because however, this can occur with meningococcal or gonococcal septicemia, staphylococcal streptococcal infection, cryoglobulinemias, and so on. So it itself has a differential diagnosis. But remember rickettsioses as well for such clinical manifestation.
Sorry, sir.
Right.
We are already ran out of time. So
Okay, right. I'll stop there. Right. Okay, sure. Right. So I think I gave a little bit of glimpse of rickettsial diseases for you. So I wish you all good luck for the rest of the days that you're in conference. And thank you very much once again for inviting me for this symposium. Thanks.
Thank you, sir. Thank you for your great presentation. Since we are running out of the time, we'll proceed into the next topic of a glimpse to the infectious disease. So the next topic would be emerging paradigm of surgical site infections. It's my great pleasure to introduce the speaker, that is Dr. S. Thuraisamy Sharma. He's graduated from University of Jaffna in 2003, and he's completed his MD General Surgery from Postgraduate Institute of Medicine, University of Colombo. He has got his overseas training in Singapore, and he has board certified as a specialist in general surgery in 2012. He is a member of Royal College of Surgeons of England as well as Edinburgh. He has completed PG certificate in medical education of Postgraduate Institute of Medicine. He is currently working as a consultant surgeon, head and senior lecturer, Department of Surgery, University of Jaffna. It's over to you, Dr. Sharma, for the presentation.
Good evening, all of you, and thank you, Chairperson, sir, for the kind information, and JMA, the organizing committee, and the council for inviting me to deliver this topic on surgical site infection in this 80th anniversary annual session. And of course, the time is running, and the speaker also old, the topic also very old. I don't know how to do in an attractive way to keep the audience awake. But my presentation is very simple and the basic, because the targeted audience are postgraduate trainees, medical officers, and the medical students. And of course, we have to think about basic, which is very important. Sometimes we go for advancing, but if you forget the basic, ultimately end up with a problem. Therefore, my discussion is very basic. And this is one of the pictures of the patients who has underwent some surgeries and ended up with a very deep surgical site infection. Actually, this is a 101st infection for the surgeon, but first for the patient. Very, I mean, burden for the patient, family, and economy. Therefore, we have to think about how we can prevent, which is very, very important. The topics are a little bit about the introduction and types of surgical site infection, clinical features, contributing factors for developing surgical site infection, managing surgical site infection, and preventing measures. That is very, very important, preventive measures. And what are the challenges we have in implementing the preventing measures, and how we can overcome the challenges. We all know the definition for the surgical site infection. That is infection occurring up to 30 days after surgery. But in case of implant or prosthesis, we have to define the time. It will extend up to 1 year, either at the incision site in the superficial tissue or deeper tissue, or maybe organ or space. It is most preventable healthcare associated infection. We have to think about that. It is most preventable healthcare associated infection. We should understand the gravity. Actually, most costly hospital-acquired infection with an estimated annual cost of $3.3 billion American dollars, and is associated with nearly 1 million additional inpatient days annually. But in our setup, there was a study done a couple of years back in this region and presented in the JMA as well. Otherwise, there are no promising data in this region. Therefore, we need to do more audits and researches to set up preventive measures in our region. If you look at the global data, it's the most frequent type of healthcare-associated infection in low and middle-income countries, as well as in first world country also, and affecting on average of 11% of the patients who undergo surgical procedures. If you look at the Western country, about 80,000 hospitalized patients in Europe, they have got surgical site infection. And then in the USA also similar kind of data. Look at the type of surgical site infection. It can be superficial, where only the skin and the subcutaneous tissue is affected at the incision site. And if it is deep surgical site infection, it go beneath the subcutaneous tissue up to the fascial layer and the muscle compartments as well. Not only that, the surrounding tissue also can get affected. But the more advanced one, the organ or space surgical site infection, it occurs in any area of the body other than the skin, muscles, and surrounding tissue that was involved in the surgery, includes body organs and the space between the organs. Look at the clinical features, from minor symptoms to systemic symptoms. If you look at the superficial infection, the symptoms are redness, delayed healing, fever, pain, tenderness, and all the features of inflammation. And some patient might have a purulent discharge. The deep surgical site infection produce pus. Wound site may be reopened on its own, and there may be an abscess in the deeper plane of the surgical site. And the organ and space surgical site infection, there is a purulent discharge from the drain side, and there may be a deep-seated abscess also identified. Look at the contributing factors. There is a big list. I don't know, I cannot label one by one because it's time factor. But if you look at that, it is multifactorial. Not only the patient factor, surgeon's factor, and the preoperative measures, theater conditions, postoperative management, everything contribute this development of surgical site infection. And if you look at the wound type, we all know that if you are talking about surgical site infection without talking about this wound type, it is not completed. You can classify the wound into clean, contaminated, and the dirty wounds, depending on the degree of possibility of postoperative surgical site infection. And if you consider the management, actually, established surgical site infection is very, very difficult to manage. Therefore, timely recognition and appropriate treatment is very, very important. And most surgical site infections, they respond to the removal of sutures with the drainage of the pus and prescribing appropriate antibiotics. That is very, very important. We have to take the culture and do the antibiotic sensitivity test. Without that, we cannot start, but sometime empirically with the evidence, we can start some antibiotic. And very occasionally, we need the wound debridement, and sometimes we have to keep the wound open and let it to heal with a delayed primary suturing or secondary suturing. But the difficult one, as I mentioned earlier, the established surgical site infection, we need a careful monitoring. It is multidisciplinary approach. Surgeon cannot alone manage. We have to get the help from others also. And effective communication between the team members is very, very crucial to manage this established surgical site infection. And very important one is the preventive measures. The important one is event reporting instructions and surveillance, which is very, very lacking in our part of the world. None of us are reporting if they develop a surgical site infection other than in our morbidity mortality meeting. There is no proper communicating channels available to report this surgical site infection. Therefore, urgently we had to establish an event reporting mechanism. And importantly, the patients also has to be taught. They also have the responsibility, especially when they are undergoing a major complex surgery in the preoperative phase. We had to educate the patients and caretakers when we take the consent for the procedure. And there are measures in the preoperative phase, intraoperative phase, as well as postoperative phase to minimize this surgical site infection. There are several aspects in the preoperative, intraoperative, postoperative phase, but because of the time factor, I don't want to discuss one by one. But very important ones with the evidence, level evidence, few of them I can touch, I hope. The hair removal, preoperative hair removal, which actually most of our units, we still follow the traditional way of shaving before surgery that will actually not practice worldwide, but most of the people are doing clipping, on-table clipping before surgery. There is also there are advanced technology available. You see that one article published in the American Journal of Infection Control. They have a nice clipper, and they don't let the hair to spill out on the operating table or on the patient body. There is a space also, kind of a sucker. Without spilling the hair, they will remove it. Similarly, there are evidences for each and every areas with a level 1 evidence. Actually, we have to discuss in detail in another forum like a workshop, then we can produce kind of a, formulate kind of a program for us. Similarly, that preoperative decontamination of the operating theater also very important. You can look at some of the new advancements they are employing in America, like movable UVC robots. And there are some lights which are actually helping to kill the bacteria, maintain the theater aseptic. And the other one is in preoperative phase, the other important thing is antibiotic prophylaxis. Depending on the type of the wound, when we are talking about the type of the wound, we have to think about the antibiotic prophylaxis also. Of course, we all know for the clean surgery, we don't give antibiotic prophylaxis, but there are indications in the clean surgery as well, like when you are going to put a prosthesis or surgery in some important organ like neurosurgery, they do consider the antibiotic prophylaxis, provided if we know that likely pathogens like Staph aureus, Staph epidermidis, and some Streptococcus species which cause the infection in the clean surgeries. And similarly, clean contaminated surgery also we have to think about the mixture of organisms, anaerobes, aerobes, gram-negative and positive. But the contaminated and dirty surgery, of course, we have to think about antibiotic therapeutic dose, not the prophylaxis one. These are the recent recommendations on antibiotic prophylaxis. We have to give actually a particular time before surgery. You don't need to give for all the clean surgery. As I mentioned, some of the clean surgery and the clean contaminated surgeries are needed with antibiotic. And we have to use the appropriate one. That is very important. Of course, I observe here we are using several antibiotics, but whatever we are using for therapeutic, we should not use for the prophylactic. We have to work with the microbiologist actually to develop a protocol. What are the antibiotics we can use for the therapeutic and prophylaxis for particular surgeries? And similarly, there are intraoperative measures. There are a lot of mechanisms or measures we can take. The one we have some doubts whether we have to apply drapes, because some of the surgeries or surgeons, they prefer to apply drapes. But there are no such evidences. Level 1 evidences show that drapes are helping to prevent the surgical site infection. Similarly, the postoperative phase also, we can take a lot of measures. The one with the evidence, changing of dressing. Sometimes we do operate. Next day, maybe a junior colleague could have removed the dressing to see what is happening there and don't do a proper dressing. Actually, they don't know what to do. Actually, we have to do a inspection of the wound and aseptic condition with a non-touch technique. Of course, our staff nurses are very good. They have got a good training, but doctors, we make all the time mistakes, and sometimes we don't follow the protocol. That's the reason ended up with a badly infected surgical site. And there is a WHO 7S bundle to prevent the surgical site infection, because you would have seen the previous slides, a lot of things can be considered, but that is not possible. If a lot of information is there, I don't know whether we can follow it, but the WHO has produced 7S bundle to prevent this, that safety, screen, showers, skin preparation, solution, sutures, and skin closure. And therefore, we also have to think about developing a bundle to prevent this surgical site infection in our area. But we have to collect the evidences. It should be evidence-based, and it should be tailored to our setup. And it should be very minimal, 5 or 7, not too much, as I already mentioned. It should be dynamic and evolving. It should be acceptable by the majority. That is a problem. Sometimes majority people say, no, we don't have faith of this bundle. Therefore, it should be acceptable by majority and affordable as well. But what are the challenges in preventing these measures? One is lack of data, as I mentioned already, and lack of local barriers. The local barriers. If you look at the barriers, maybe a clinician side, there are barriers because of the knowledge, attitude, behavior, and compliance. And there are factors in the hospital as well, the tasks, tools, and technology like that. And the guidelines, whether it's applicable or acceptable, is a problem. Therefore, how can we overcome these challenges? We have to transform the healthcare to address the challenges as this year theme. That is very, very important. As yesterday the guest of honor and the chief guest has mentioned, we need a governance, good governance, and we had to establish an incident reporting system empowering the non-medical staff. The hospital I did my postgraduate training, there is a infection control nurse and the wound care nurse. They are doing a good job. They do a research and statistics. Sometimes they present in the forums also. The surgery department last month, 46% did can washing. This month, 35%. Like that they are doing. I asked how they are doing this calculation. They have a CCTV camera also on, but there are dedicated staff to observe these things, because it will cost a lot of economic crisis for them if the patients get admitted again to the hospital, a lot of patients. That's what they are empowering the non-medical staff. We also have to think at one point we had to empower our nurses. Develop a dedicated surgical site prevention team. Identify local barriers to implementation by observing the staff performing the interventions. That's, I don't know how extent we can implement. Walk the process to identify the defects. Invite the stakeholders to share concerns and prioritize the barriers to improve compliance, and establish a framework for developing action plan, which should be specific, measurable, achievable, relevant, and the time bound. Otherwise, it is not going to give an important benefit. And we had to engage the people, we had to educate the people, we had to execute, and we had to reevaluate whether it is suitable for our environment. And my take-home message in terms of preventing surgical site infection, you all know it's high epidemiological burden and economic burden to the country, highly preventable infection. There are no recent evidence-based guidelines locally. Therefore, we need a workshop, actually speaking. Next year, the president-elect is one of the surgeons, Professor Rajendra. I hope that with the help of the Department of Surgery and other surgeons in the health department, we can organize a workshop, a brainstorming workshop on preventing surgical site infection. This is my request. And we need more and more audits and research locally, and we have to establish evidence-based guidelines locally. The more importantly, we have to translate the evidence into practice. That is, we have to synthesize of clinical effectiveness evidence and clinical practice guidelines. Otherwise, it is a waste of time and money. Thank you for patience.
Thank you, Dr. Sharma, for your excellent presentation. As we all know, the surgical site infection is the most common surgical complications and a serious threat to the patient's health and life. Since we have got few minutes, we entertain some time for the questions. Is there any questions from the audience, please? Yes, in the absence of any questions, I take this great opportunity to thank Dr. Sharma on behalf of this JMA for his excellent and informative talks. Thank you.